Welcome to the Every Mom is an Athlete podcast, where we believe that motherhood is inherently athletic. I see you lifting car seats, chasing toddlers, and carrying groceries one-handed while holding a baby and a coffee. Your daily life is a workout. I'm Dr. Karlie, pregnancy and postpartum expert, sports chiropractor, strength coach, entrepreneur, and mom of 3. Here you'll find solo episodes and real conversations with other moms and leading experts, so you can live your strongest, healthiest, most aligned life in motherhood. No matter how long it's been since you've had your baby, whether you're reconnecting with your body, rebuilding your strength, or just figuring out what feels good again, you're in the right place. All right, Dr. Rachel, thank you for joining us today. I'm so excited to talk to you about pelvic floor PT.
Me too.
Yeah. Rachel and I have been friends and actually patients of each other's, which is pretty cool. And she is just my go-to pelvic floor PT referral for all my patients. In fact, I think she's like too busy. I have to beg to get them in with her. But before we get started, Rachel, I have a couple questions. I want first for you to tell us a little bit about yourself. Just give us a little bit of your background. And then we really need to sort of define pelvic floor PT and the pelvic floor in general so that we're all on the same page. So let's start with you. Tell us a little about yourself.
Yeah, I am a physical therapist. I've been a PT for almost 20 years now. And I have a background in sports. I played college soccer. So initially I did orthopedics and I love that. And then I eventually found my way into pelvic health because it's just an area that is underserved, but yet helps you appreciate the rest of the body. And I think the peripartum population really helps marry orthopedics, sports, activity, and also just a need for pelvic and women's health.
Yeah, for sure. So on that topic, would you define the pelvic floor for us, in layman's terms so everyone can understand?
Sure. Yeah. I always kind of do anatomy and give a spiel with my patients. So I'll kind of summarize that. I'm someone who really thinks about what each word really means. And so if you think about what that means, it's the bony pelvic ring. It's the floor of that bony pelvic ring, and it's the muscles that make up that floor. Those muscles, there's 3 different muscle layers, and the overall functionality of all of those muscles collectively together is to stabilize that bony ring and provide support and load transfer from the lower extremities through the pelvis up to the torso, and then conversely the opposite way as well. So stability, right? It provides stability of that bony pelvic ring. There's a sexual function as well. Those pelvic muscles also have to be strong to help us have orgasm and good sexual appreciation. There's a sphincteric function to those muscles. So the sphincter muscles that control the openings around the urethra, vagina, and anus, they have to be strong to hold things in, but also be able to relax to let things out. The pelvic muscles in general, with breathing, which we'll talk more about in a minute, provide almost like a sump pump action, helping lymph and blood flow kind of pump in and out of the pelvis and assist with breathing. And there's many, many other functions. But in general, I think of stability as a lot of what we talk about in rehab.
Yeah, thank you. That is a great explanation. So speaking of rehab, let's give people an idea of what pelvic floor physical therapy means, because I still find, which is sort of crazy, we live in this world, so right? So it's like, of course, everyone knows what pelvic floor PT is, but truly a lot of people don't really know what pelvic floor PT is. And I get messages on social media all the time asking me what it is, why people need it. So just kind of walk us through what pelvic floor PT is and what that can look like for people.
Yeah, I mean, that's the funny thing is there's not like a specific definition, and there's different levels of training that different people have that, if they're marketing themselves as a pelvic PT. So for example, you can treat the pelvis and pelvic floor muscles externally. That's one way to do it. And so you could call that pelvic PT. But a lot of pelvic floor therapists do internal pelvic assessment via the vaginal canal or the anal canal. And really what we're working with is people who have either like pelvic pain or dysfunction, bowel or bladder problems, or prolapse. Those are some of the big areas focused in the pelvis. But people can have other problems in addition to it, back pain and pelvic pain. So it's not a defined line of orthopedic versus pelvic. But when I think of pelvic floor therapist, I think of someone who's trained to do the internal pelvic floor assessment.
Yeah. And I want to just touch on a few things there just so that listeners know. Correct me if I'm wrong, okay? But it is not a requirement as a patient to do and have internal work done, correct? Like if I come in and I'm uncomfortable, right? Like that's not a requirement.
Definitely. That's part of it too, is assessing appropriateness
Mm-hmm.
for that type of assessment and also having consent. So informed consent and appropriateness. It's not for everyone.
Right. Yeah. Thank you. And then the other thing that I get a lot of questions about, and I think it'd be just good to define, can you talk just briefly about what prolapse is and what can prolapse? Because I find that prolapse is sort of a catch-all term, right? And so can you just define that a little bit for us?
Yeah. So prolapse is in general when like an organ just isn't quite where it should be. So, for example, in the vagina, right, there's a front wall of the vagina and there's a back wall. So, that let's say if someone has a cystocele, which the prolapse is always named for what is prolapsing. So, that's when the bladder is displacing into the front of the vaginal canal. So, that's a cystocele. So, things that are displacing in that area can be the urethra, the bladder, the rectum. Sometimes the uterus can come down as well. Sometimes even some of the intestines. So there's several things that can prolapse. And the name of prolapse is just whatever is. So rectocele, cystocele, urethrocoele, urethrocystocoele, enterocele, right? And so they're all named for that. So prolapse is a catch-all. And basically it just means that something is kind of stretched or maybe loose. So that connective tissue is loose in the front of the vaginal wall when the bladder is pushing down. And that bladder is just displaced a little bit. So that's what prolapse means.
Yes, thank you. So let's talk about the pelvic floor PT appointment now. So I come in, which by the way, I have seen Dr. Rachel, so I know exactly how this works, but we're going to walk through it just for everyone else. If you're interested in pelvic floor PT and you're like, I just have no idea what it could even look like, I just want to give like sort of a brief idea. So I come in, when do you first recommend, let's say I'm postpartum, when do you first recommend that I come?
Yeah, it really depends. That's a great question that I have a lot of times, especially if I'm working with someone in their pregnancy and we want to kind of get them back on track of postpartum. So the great answer is 6 weeks is a really good time to do assessment. There's a normalcy of healing. So the urinary and reproductive tracts take about 6 to 8 weeks to return to a non-pregnant state. And then also during pregnancy, our immune function is lower. And so we want that to kind of start returning to a baseline. So point being, we don't want to do a lot of internal things until that 6 week mark. But that doesn't mean that you can't come to PT before. I've had patients as early as 2 or 3 days postpartum come back to me. Let's say they injured their pubic symphysis during vaginal birth. So there's a lot we can do to help them. So my great answer is like, if I'm working with someone in pregnancy, I say, let's just go ahead and schedule a 6 week follow-up if that's, something you're interested in. And at that time, we can assess what your needs are. I'll usually give them stuff in the in between to work on, like what's appropriate those first 6 weeks. And then let's do an assessment around 6 weeks of abdominals and pelvic floor. But I say if you're, when they give birth, they have precautions, right? Like if you have abnormal bleeding, things like that to check back with the physicians. But if they are having some musculoskeletal pain that's impairing their ability to care for themselves or their new baby, then they definitely could do some treatment. In Washington, we're a direct access state, so they could just come see me. But I always want to work with their obstetric care provider too and just make sure we're not missing something. So the answer is anytime, because then the third variable, as you know, being a mother of 3 yourself, is also, that's great, but what if you don't have any childcare or, you yourself aren't feeling up to it? That's okay too. So anytime. So 6 weeks, if there's a problem before that, come in. But 6 to 8 weeks is a nice time because the reproductive and urinary tracts are returning to that non-pregnant state and some healing has to occur.
Yeah, that makes sense. I always tell my patients, it really, like the same thing, it depends, right? But I always tell them, if you're feeling the need to come in before that 6 week mark,
Always.
yeah, for sure come in because there are other things we can help with. I have a lot of patients who, especially moms that are like second or third time moms that know what's coming, that are like, I know how bad my neck is going to feel and my upper back from nursing. I know that my wrists are going to hurt. And so it's not always pelvic related. I'm like, yeah, we can check your pelvis, but we're going to be gentle, right? But we're not really going to focus on checking your ab separation, checking your pelvic alignment as much until, a little bit later. But like same thing, I've seen patients 2 or 3 days because they just know like my back is going to need some help and like I know how much better I can feel. And I think that's great. Everyone can sort of make that decision for themselves based on so many factors, right?
Oh, definitely. And like, one example is I had a really good friend who's an OTA and first birth, she strained her pubic symphysis so bad she couldn't even walk. She had to use like a walker and nobody was helping her. And, really I just had to show her a few things and get her a pelvic stability belt. And that increased her functionality because she couldn't even care for her baby because she was a single mom. So, point being, if you're having pain, it doesn't have to be pelvic floor or anything like that. As you just mentioned, some of the things we see a lot in our postpartum mummies is neck pain, wrist, arm, or any of that upper extremity stuff as well because of the constantness of baby care.
Yeah, for sure. And what about babies? So I know in my office, I always tell my new moms, like, you are more than welcome to bring your baby in. Would you say generally that women are able to bring their babies?
Oh, definitely. I do not want that to be a hurdle to their care. We can get something meaningful done no matter what. I do know a lot of my patients prefer not to just because they can't focus. But if you're in pain, we can always work around. That is one of the hurdles for people in general who have children to exercise is availability of childcare, finances, time. I never want that to be a hurdle. So I always say, hey, if you can't find childcare, just bring the baby in.
Yeah, totally. I love that. I know some moms, like you said, are hesitant to do that just because, they want to be able to focus on themselves. And I get that. My office manager ran a daycare for many years. So I'm always like, we can bring her in. She'll hold the baby for a few minutes. I'm like, we're going to make it work. We got extra time if you need to nurse, whatever you got to do.
Yep. Well, and then I get my baby snuggles too, because my daughter is like 9 now and I miss babies. So I'm always like, I don't mind as long as you're okay with me touching your baby.
Yeah, that's awesome. I love that. Let's switch gears a little bit because I know one of the things that I harp on a lot, talk about a lot is, we talk about the pelvic floor. We talk about it being weak or tight or Kegel. So, whether or not we need to be doing Kegel. So can you tell us what is the difference between a weak pelvic floor and a tight pelvic floor? Like what are some things we might be looking for?
Yeah. And we can speak in absoluteness and then we'll kind of muddle it.
Yes.
So obviously a weak pelvic floor, because there's like a continuum of weak, tight, and then there's people who can have both, not to overcomplicate. So when we think of weak, those people in general may have complaints of like fecal or urinary leakage, or they might have symptoms of prolapse, which would be like feeling of heaviness in the vagina or pressure down there, or they may actually physically feel something. Those are some of the things. Some pelvic pain can be either or, right? It can be tight, it can be weak. People who may be more on the tighter pelvic floor side might tell you something like they have pain with sex or penetration. They have constipation, so difficulty evacuating. They may have some urinary hesitancy or urgency. But not everyone, as you know, is absolute and clear cut. Those are just kind of the two sides of that continuum. There are also people who are in between who can have weak but tight pelvic floor. And those are the ones that require a little bit more length of intervention.
Yeah, and that makes sense too, right? Because when we're talking about the pelvic floor, we're not talking about like one muscle, right? So it makes sense to me when you explain it that way. It's like, well, of course, like my bicep can be weak and my tricep can be tight, so it's like the same in the pelvic floor. Like one muscle might be weak, one might be tight. And so that's what I always tell people. It really takes some evaluation. You can't just guess, right? Like I wish we could, but really it's an evaluation is needed most of the time.
Yeah, and that's where our objective assessments really come in, right? Because I could listen to someone tell me their symptoms, and as you do in your practice too, you're forming your hypotheses, thinking about what you're going to check. And you're like, well, do you want me to just tell you what I think it is, or do you want me to actually find out? And that's where some of that internal objective assessment really gives us our data points to confirm what our hypothesis is from that subjective interview. And as you were kind of talking about, a muscle can have trigger points, which can inhibit its ability to function. And so we need to be able to see if those muscles have those as well.
Yeah. And even personally, I'll tell you guys, when I went in to see Rachel, I don't know what it was, probably 6 weeks ago or so, but we had been in Hawaii and I got knocked around in some waves. And I truly thought that I had torn my labrum in my hip because it just felt like something I'd done before. And I sort of forgot about it. And this is crazy too. I know as we get older, it's like, oh, how did you do this? How did you do that? Like, I don't know. And you kind of forget. And then anyway, she jogged my memory. I remembered that I hurt myself that way. And she did do an internal evaluation. And I think that was one of the, I mean, I've seen you, I guess, after all 3 of my births, but I think that was one of the first times as far as like needing that evaluation and then the release of those muscles, because as soon as she hit on a few different muscles, it like referred straight into my hip where it hurt. And it was wild. And then it released, right? And it's just like another muscle, just like a trigger point you might feel in your trap or, your upper back. Once that releases, you move better, you function better, it's less painful. So then she can touch that muscle again. And I'm like, oh yeah, now that doesn't hurt. So anyways, I just share that because it really, while it is like, sort of an awkward and very like intimate relationship to have with a provider, it is just so beneficial. And I work externally on the muscles on people, but I just think sometimes you need that internal, for certain things, you need that internal release of certain muscles, and it can just be a game changer.
Yeah, and I think what you're highlighting there is one of the main reasons actually why I'm in pelvic PT is because it can just help you treat everything a little bit better, right? We talked about the pelvic floor muscles per se, but what you were alluding to there is the connection between the hip and the pelvic floor. So obturator internus, which is a hip external rotator, connects into levator ani, the deep stabilizing muscles of the pelvic floor. So most of the time, someone's not just, they might be in my office for something like incontinence or, something you label pelvic floor. But when I go through that subjective history, like, oh yeah, they have right hip pain and they have back pain. And as we kind of talk more, we'll allude to how all of these things are kind of interconnected. And that's actually why I love treating the pelvic floors, because you can usually treat the back and the hip so much better, and ribs and all of those things.
Yeah. And I think as a chiropractor over the years, I've also become more keenly aware of pelvic floor issues. And I know, not to toot my own horn, but I'm pretty good at treating back pain, right? I'm pretty good at knowing what needs to be adjusted, what needs to be loosened, what needs to be stabilized, and putting people on a program to get better fairly quickly. And if they're not getting better within a few visits, I know 15 years in practice, I go back and I reeval like, okay, wait, let me think. This person has had 2 babies. Did they do any pelvic floor PT there? We look back at some of the history, and sometimes they're not. I want to be clear about that too. Sometimes it's not people who have had kids. Sometimes it's men. Like it can be issues. And so I just mentioned that because if you have recurring back pain that you feel, or hip pain that you feel like you've done all the things, if you haven't had your pelvic floor evaluated, that's like another way to go to look into, because it's just like you said, it's sort of like it's the bottom of our core, right? That's what I always explain to my patients. We think about our core as a barrel, the top is a diaphragm right under the ribs, the bottom is the pelvic floor, and then you have all the muscles around, the back muscles and the ab muscles and all that stuff. So it makes sense that it's connecting everything, right? So it could just be one of the things that you want to look at.
Yeah, you said so many good things there that made me kind of ding several times about. And that's exactly what I teach. So I do teach peripartum rehab. And when I'm teaching, let's say not everyone wants to be able to do internal pelvic assessment. So we do teach external versions. And I think of that as kind of screening. And when I'm teaching that, how do I know if they need to go to a pelvic floor therapist who will treat these things internally, is usually if they're not getting better within, a few visits, then they really do need to probably have that more in-depth assessment. So kind of layers of knowledge.
Yeah, totally. I appreciate that. Just a quick pause. If you're feeling like your body doesn't feel like yours anymore after having a baby, If you don't know where to start or you're tired of guessing what's actually safe postpartum, I've got you. I created the Postpartum Restoration Plan to give moms a clear, doctor-designed roadmap to rebuild strength, support their core and pelvic floor, and start feeling strong again. It's just 4 days a week, under 20 minutes, and built for real postpartum life. Whether you're a few weeks or a few years out, it's never too late to start. Click the link in the show notes and I'll walk you through it. Let's talk a little bit about Kegels. So everyone wants to talk about Kegels. So I know Kegel's a little buzzword. I feel like Kegels are like, they're like the other things that just go in and out. Like coffee's good, coffee's bad. Kegels are good, Kegels are bad. And with everything, it's like there's always shades of gray. So just give us a rundown of what are Kegels? When are you recommending them? Should people just be doing them like, willy-nilly, like everyone should be doing them? Is that true or false? Like I just asked you 12 questions, but go ahead and talk about Kegels.
All right, I'll do my best. And if I miss something, you just ping me again. So Kegels, I always say, so Kegel is just the name for contracting and relaxing your pelvic floor muscles. It was given in the 1940s. There was a physician, Dr. Kegel, who would have his patients practice contracting and relaxing their pelvic floor muscles around the time that they were having children, and that was going to help with stuff. And it does help some people. If some people have the problem of weakness, Kegels are going to be helpful for them, but they're not helpful for everyone and may not be the best to be just kind of blanketed to everybody. Just like upper track work, right? You wouldn't just give everyone upper track work. Some people who have a lot of tension and pain up there, that would be detrimental for them. So it's the same with Kegels. So if someone has incontinence, you could say, once again, I'm just being kind of gray here. You could say that they probably would benefit from Kegels. But just as you would prescribe someone exercise, Karlie, you're using your skills to dose it, right? Mm-hmm. So for example, if I haven't done an internal assessment and checked their strength and endurance, and I'm blanketly telling them to do an exercise, there is potential for problems, right? They could overdo and increase their incontinence because their muscles are exhausted. They could overdo and get a lot of soreness and trigger points, which could inhibit their ability to use their muscles. So that's where, like, number one, blanket giving Kegels in general, but also like the need for specificity is also important. So that's one area. And then we kind of talked a little bit about how there's also some people who are really tense and tight. And for some of those people, teaching them to contract and relax can be helpful, but not all of them, right? Some of them, it's going to make their tension worse. And that's where individualized assessment is important. So I don't know. Did that answer those things?
Yeah, I think so. What would you say, like, I know this is probably a hard question to answer, but what would you say, like, percentage of your patients? How often are you prescribing Kegels?
So I'm going to use an example of someone who has a lot of tension, but they also have incontinence. So that person, it's more about timing of when you give them. You have to release all the trigger points, get those muscles in the deep core functioning better. Then you can dose it. But if I'm just talking about in general, let's say during pregnancy and postpartum, and they're having some form of incontinence, whether it's urinary or fecal incontinence or some prolapse symptoms, I would say like 75% of them are getting pelvic contractions. And then I would increase that number if I say at any point during treatment, meaning like if I have ones that need some pelvic tension releasing and we're working on mobility for a few weeks, and then they can have it. So majority of people, yes, when used the right way. Sometimes you focus more on the relaxation of the muscle after the contraction too. So a lot of people get them, but it's just dosed in a different way.
Yeah. And I think that's one thing people don't understand. And actually, I found really interesting was the amount of strength versus endurance, right? Because those muscles, some people can contract them, but then you ask them to hold. Let's hold for 5 or 10 seconds. And it's like, whoa, now I can't do it, right? So those are things that, like, it does take a trained eye to help you figure out, right?
Well, to bring it back to just basic muscle physiology and anatomy as well, you have fast twitch fibers and slow twitch fibers. So fast twitch fibers being your power muscle, right? That they engage quickly and they generate power and a lot of excursion of movement. And then slow twitch being more of your endurance, postural, low intensity, prolonged hold muscles. In the pelvic floor, 70% slow twitch. So a lot of postural, a lot of endurance, a lot of stability. But that other 30% of the quick, powerful, fast twitch muscle is a lot of the sphincters, right? So like if a big sneeze is coming, you need to be able to engage that quickly and powerfully. So kind of what you were talking about is the intensity and endurance are also elements that need to be individualized.
Yeah. And you mentioned one thing there that sort of jarred my memory of another question I wanted to ask. When we're talking about prolapse, going back to prolapse real quick, where I hear it most often described like something feels like it's falling out. And then whatever that is, right? Could be different organs. Is there a time when that prolapse is normal after giving birth, when it's normal to feel that?
No, it's never normal to feel that. What else do I want to say about that?
No, that's great because I think it's just like, I'm always talking about how pain during pregnancy is common, but it's not normal, right? Like there's something you should do. And I've heard other people say it's normal to feel that, within the first week or 2 weeks after giving birth. And so I just wanted your opinion on that, if that is just a common thing or if you would actually classify as that like, oh, it's normal. It doesn't mean anything is wrong.
Yeah. And I think several of the things that we hear in that early postpartum, that 6 to 8 weeks, like I said, when things are kind of switching from a pregnant state and working their way back to a non-pregnant state, they are more common, but not normal. Yeah. But if you are feeling it, it doesn't mean just because you feel it at 2 weeks, you'll feel it at 8 weeks. But similarly, a lot of the things like, I think if I'm talking about like incontinence or diastasis rectus, things like that, if you're still feeling it at 12 weeks postpartum with no intervention, when you look at the percentages and numbers, it looks the same at 1 year and 5 years. So that's without interventions. And that's where we have tools to help with that stuff.
Yeah, I know. And I always mention that as far as diastasis goes, because I'm like, it is actually diastasis is normal, right? Those first couple weeks after pregnancy, I would say. It doesn't mean necessarily, like you said, that it's going to still be there, but it does mean that we want to start intervening because once you hit that 6 to 12 week mark, then we're like, all right, this is what it looks like. So along those lines, let's talk about breathing. I love talking about breathing. Everybody knows. Just so everyone knows, I'm not the only crazy person who wants to focus solely on breathing. I shouldn't say solely, but primarily on breathing in early postpartum. Give us a rundown of why breathing is so important, such an important piece of postpartum rehab.
Oh, well, I love that you're passionate about it because I am too, girl. I am too. First off, we all do it 24,000 times a day, so we should be good at it. And I think one of the most important things to focus on with breathing in the postpartum, there's kind of two major pieces, is just thinking about the adventure that that person's body has been on during pregnancy as that uterus and fetus grow. It crowds your respiratory diaphragm and it actually makes it harder for them to use that muscle. So that muscle can be restricted or deconditioned. And it doesn't just go back when that uterus has shrunk back down. It does in some people, but not in all. The second important part about that is that the respiratory diaphragm drives the rest of the deep core. And when I talk about deep core, I mean pelvic floor muscles, transversus abdominis, lumbar multifidi. They all function together. So if the respiratory diaphragm is not functioning well, then you can be great at training the rest of that stuff, but it will never get you where you will need to go with that person. So I think it's really important to always start there. And also postpartum, even in those first days, weeks, I mean, that's really impactful, easy work that can be done. They're really busy with childcare. They may not be used to taking care of themselves. They're just trying to kind of get used to having a child, or maybe they have multiple children they're caring for. Breathing is something we can always fit in some time to do, whether that baby has fallen asleep in your arms or you're laying down and resting. Diaphragm is so important. It drives the rest of the core.
Yeah. And I think just mentioning back, like you're talking about core, that's the top, right? Like that's the top of the barrel. And I think for me, before I had kids, I don't want to say I poo-pooed breathing work, but I sort of was like, yeah, we all breathe. Okay. But once you have felt that just crammed sensation, and I don't think you notice it as much when you're pregnant, right? Because it just becomes your norm. But then once the baby comes out and you're like, oh my gosh, I can't get a deep breath, or I just think once you can start to feel those ribs expanding, when you take a breath in, just a reminder for everyone, your belly should go out. So it should expand, right? Like as you're taking that breath in, everything's expanding. And then you breathe out, it should sort of like come back in. So once you start working on that again, you really start to feel like, okay, I feel my ribs, I feel my back muscles. And so it just is so impactful. And not to mention, right, the way that it helps calm our nervous system down, right?
Yep, definitely.
Yeah. So I think that's just, I'm always harping on breathing with new moms, and I'm not the only one, guys. So
Yes. And you shouldn't be. Like I said, it's the thing we do most in a day. And if we're doing something in a disadvantageous way 24,000 times, you can see how that can create like neck, rib, back, all of these other problems. And it can contribute to other things like incontinence, pelvic pain, low back pain. I mean, we can go on and on.
Totally. Let's talk real quick about C-sections. So do you see moms, again, I know the answer because I saw you after my C-section, but let's talk about rehab, recovery, pelvic floor, specifically recovery after a C-section.
Yeah. So I'll kind of contrast it a little bit with vaginal birth. So if you've had a cesarean birth, you were pregnant. And so anytime you've been pregnant, there is some stretching and weakening of the pelvic muscles as well as the abdominal muscles. And so just because you don't birth through the vaginal canal doesn't mean you don't need pelvic rehab if you've had a cesarean. Also, was this a planned cesarean versus like, did someone labor and there was a problem? So maybe they've done a lot of that pushing and some of that stuff that can lead to postpartum issues in the pelvic floor, but ended up having a cesarean on top of it. And we were just talking about how respiratory diaphragm, abdominals, pelvic floor, multifidi all work together. So if I've had disruption of those muscles via the surgery, then something isn't going to be working well. And I need to rehab whatever part of that deep core isn't working. So maybe the pelvic muscles are working too hard because the abdominals aren't doing their stabilization, right? I don't know. But just because you had a cesarean doesn't mean that you don't need pelvic floor care. The other important thing I think when we're thinking about postpartum recovery is any abdominal surgery, you have lifting restrictions acutely to protect that incision. We want to maybe prolong our return to high impact activity. So the general recommendation for vaginal uncomplicated birth with return to high impact activity, meaning feet leaving the ground, is about 3 months. That's kind of expert opinion. If you've had a cesarean, it might take you a little bit longer to get back to that point. So those are kind of my main points.
Yeah. I think that's really helpful because there is a difference, right, from doing some exercises on the floor, some even squats, even starting to lift weights, and that jumping and that impact. Talk a little more about that impact for just a second, because I know you have some interesting stats on, what is the stat again of how much force it is when you leave the ground?
4 to 5 times the impact of walking. So
That's wild.
running is, I know. And so if you think about I think, it's something that maybe someone did before, so it doesn't feel like it's such a drastic change. But when we're really kind of breaking it down to prevent some of these problems, expert opinion is really 12 weeks with an uncomplicated vaginal birth to return to high impact. But as we know, and that's why I love Karlie, is because we're both passionate about early strengthening. You can do so much. There's so much you can do. So really giving the patients the mindset of like, oh, well, I know that running is like your goal right now, but the best thing for you to do is actually strengthen all of these muscles that maybe changed a little throughout pregnancy and get you back to where you can safely return to running. It's not that you can't, but we want you to do it in a safe way where you're not going to get injured. Because now if you're injured, it's impacting your whole family, maybe not just yourself.
Yeah, and I think that people are always surprised when I tell them what I have personally done, and when I also tell them what my postpartum plan looks like, where you really are doing glute bridges, hip stability drills, hip hinges, squats, really within the first couple weeks if you had an uncomplicated vaginal birth. And for me and for many of my patients, that actually feels better than even walking, those first couple weeks, because if you think about it, what you're doing, like you just said, is you're stabilizing the hips, the pelvic floor, you're using that breathing, you're tying it all back together and like reminding your body like, hello, this is how we all work together, and just going out, even walking, running, it's not going to do that in the same way because you're just not ready, right? Your body is physically, anatomically not ready until you've done some of that stability work.
Yeah, because if you think about it, during your pregnancy, your center of mass changes. So your muscles are all
Mhm.
functioning just a little bit different. And then all of a sudden one day, they're not. And so I don't know if you experienced this, but I really felt like, I was a college athlete like yourself. And like that first week or two, I felt like I did not know how to move my body. And that was a
Yes.
very uncomfortable feeling for me as someone who's pretty coordinated and athletic. And I would say that, we both were pretty active through pregnancy and do a lot of strength training and activity. And for someone like us to even feel that way, I was like, oh my gosh, I couldn't even stabilize myself sitting in a chair. It was wild.
I know. I remember I had a patient who's also a friend of mine who's a really high level CrossFitter. And I had mentioned to her before she had her baby that she was going to feel the weakest she's ever felt in her life in those first couple weeks postpartum. And that was okay, that was going to be normal to just not recognize her body. And she told me later that she really appreciated that because it set her up to not be surprised and not be worried and like to know, okay, this is why I'm starting with my breathing, I'm starting with my bracing. And then it does come back rather quickly, right? But it is shocking. I think, especially for first time moms, those first couple weeks, you're like, dude, I used to be able to like lift 300 pounds, deadlift 300 pounds. And now I can't like get myself out of bed. It's wild.
It is, it is. And I think you said something in there about you gave her not permission, but expectation. And that's something I think that when I love working with someone through pregnancy, because then I can give them appropriate things to focus on. Because one of the biggest complaints I hear to someone who's coming postpartum is like, I want to exercise, I don't know what to do. And that's where like I love your guided program. I love programs like that because it gives people somewhat of an expectation of what's normal. Because
Hmm.
if it's a first time parent and this is new for them too, and you can't compare your pre-pregnancy self to your pregnancy self to your
Right.
postpartum self because it will look different based on your levels of what you were able to do.
Oh, gosh, we could just talk for hours, but let's wrap up here. I've got 5 kind of fun questions. Are you ready?
Yes, I'll try my best.
Okay. So, just a few fun questions. What is your go-to coffee order on a chaotic day?
Oh, it's almost always a 16-ounce Americano with white chocolate and a little cream. And I go
Yes,
hot in the winter and iced in the summer.
you do. You're one of those. I go hot all year long and people think I'm crazy, but some people go ice all year long. We're all our own special brand of crazy.
It's true.
What is your favorite kind of core cue when you're teaching people how to use their core that you might find yourself saying over and over?
Yeah, for the transversus abdominis, I always have them. So if you're looking at the pelvic ring, like we'll use our words of the ASIS, but I'll call them the front pelvic bones for people. I always say, imagine you're pulling those together toward midline, almost like you're like putting on tight pants. That's one of my more favorite cues because I think that helps people kind of activate transversus and pelvic floor muscles together if that's what they really need, if they need that stability around the bony pelvis.
And that is also one of my favorite cues because I stole it from Rachel many years ago.
No, it's not mine. I mean, I don't know where I learned it, but that one resonates.
It does. Yeah, I use that with a lot of patients too. What is your favorite movement or stretch that you do when no one's watching?
Oh, I mean, I love a good hip flexor stretch, but sometimes, in public, it's like you're thrusting your pelvis forward and stuff. So that's the one that I feel like is my special, like when I can do whenever.
Yes, in the privacy of your own home.
Yes.
What is your least favorite postpartum recovery myth?
Oh, well, I kind of have two. You kind of talked about one a little earlier about how the term normal versus common. So, for example, that urinary continence is normal after being pregnant or giving birth. It may be common, but urinary leakage is, even in a little bit, is never normal. That's one. My second is more of like a term that I hear a lot in postpartum rehab that I really want to change. So maybe I'll put it out there and we can work on that in reference to diastasis rectus abdominis or DRA, people always use the term muscles are separated. I
Mm,
don't like that term because it implies that there's disruption of the connective tissues and muscles. Really, the current definition has more to do with the increased distance between the muscles. I think using a word like separated can make patients feel like there's a tear or a defect in their abdomen, which can feel really scary. It's really just that tissue's just stretched instead of separated. I prefer that.
Yeah, that makes a lot of sense. Yeah, I think I definitely use the word separation because I think
it's the literature a lot.
Yeah, it is. And I think it's easier to understand without, but I think I also make sure I'm not fear mongering it, right? But yeah, that's a good point. I think it is stretched, and it is like that kind of like idea of like if you take a rubber band and you like stretch it, at some point it's not going to go all the way back without some help, right? So yeah, that's good. You've called me on my verbiage.
Well, no, it's a fear thing, right? Even
Totally,
when I'm teaching people in rehab, like yourself and myself, that
Yeah.
like it's still not clear that that's not like a tear, and it's same with prolapse, right? That tissue is stretched, right?
Right.
Stretched tissue can be rehabbed, and I think that instills positivity for patients. So that's my soapbox.
All right, last question. If you had a billboard outside of every OB or midwife's office, what would it say?
Oh, so this is where I am like not great at marketing. I'm a science nerd. I'm a very direct communicator. I'm like good at this. So like for me, I would just say something like, I don't know, how to have your best pregnancy and birth experience yet. Come in for a consultation. Right. So I'm boring. And then I would probably just put some sort of eye-catching picture.
What do you want them to know? Like, what do you want the OBs and the midwives to know about pelvic floor PT? I guess is a better way to ask that.
Oh, man.
I would just probably put a big sign that says, send me your pregnant patients because they shouldn't be in pain, or something like that.
Or like what we were talking about, how like urinary leakage is not normal.
Yeah, right. And then just like, bam, your website.
I know. I just put like a picture that would be really like, oh my gosh.
Yeah. It's kind of shocking.
A giant
and then like
vagina flower.
Yeah. And then just like come to pelvic floor PT.
Yeah. Yeah, exactly. See, that's why I'm not in marketing.
Yeah. All right. We'll leave it to the marketers. Thank you, Rachel, so much for coming on. And I feel like we could just pick your brain about, hundreds of hours of information. But can you just give us a rundown, give everyone a rundown of where they can find you and connect with you?
Oh, yes. So I worked in Seattle, in Fremont, for Flow Rehab. I'm not really a social media kind of person. And my clinic, we're actually moving in a few weeks to a bigger new space. And so I know there's like rebranding and things happening. So it's more like go online and you can shoot a message, and then our front office like filters it to us. That's usually the best way to do it. But I'm also unsure what it's going to look like in a few weeks because we're adding more clinicians in space, which is really exciting.
Yeah. Awesome. Well, thank you so much. I really, really appreciate your time. You have been so helpful. I'll have to try to weasel you into coming back on again sometime soon.
I'm always down, Karlie. I appreciate your time too, and you helping to kind of put all this out here and hopefully answer some people's questions. So thank you, Karlie.
Thanks for listening. Every Mom is an Athlete isn't just a podcast. It's a reminder. Motherhood is athletic, and you're still the athlete you've always been. But it's not about going back. It's about moving forward intentionally and powerfully. If this episode resonated with you, I'd so appreciate it if you'd share it with a friend, leave a quick review, or rate the show. It helps more moms to hear what they need to believe, that every mom is an athlete. See you next time.